Okay, so I think we can get started. Hello, everyone. Welcome to the Healthcare AI Forum. I'm Yuan, host of the forum, and today it's my great pleasure to introduce Dr. Jie Yang from Harvard Medical School. So he's the assistant professor there and a lead investigator at Mass General Brigham. His research focused on developing and applying advanced AI and NLP LLM methods to analyze large-scale health data, including EHR. He's a fellow of the American College of Medical Informatics and a fellow of the FAMIA, and serves on the technical advisory group for the World Health Organization Global Clinical Platform. Dr. Yang received the Best Paper Award at Colin and the Best Demonstration Paper nomination at ACL. He serves as an associate editor for MPGA Digital Medicine, IEEE Transactions on Neural Networks and Learning Systems, and MPGA Health Systems. And he's an area chair for major NLP conferences, including in ACL, NLP, and Colin. So now, without much further ado, let me turn the stage to Dr. Yan, who will talk about understanding LLM capabilities on large-scale, multilingual real-world clinical data. Jia, take your stage.
Thank you, Dr. No. Thank you very much. Good morning, everyone. So it's my great honor to have been here to present our recent work to Northwestern. So the talk today is the title is the Understanding Large Language Capabilities of Large Scale of Multilingual Real-World Clinical Data. So we have a very brief kind of background introduction. So we see a lot of kind of news headlines, papers, and we claim that AI, especially large language model, have a great potential and also kind of very good performance on many medical applications. So the left figure is a one kind of classical figure we have seen quite a lot. It's the exam the large language model on the medical exam, United States medical exam data set. So just using those AI to do the medical exam question answer tasks. At the beginning, they have a GPT 3.5, the initial GPT ChatGPT model. They have reached 60% of the score. So a lot of news headlines say that okay, AI now can pass the USME, they can beat physician, they can be a real doctor, etc. And then this kind of evaluation has quickly been satirized. So when the Google has the new models, Meta 2, they have 86 and have new model GPT-4. And recently they have a new, I think if I'm not remember it wrong, the open evidence has claimed that they can reach 100% score on this kind of USME tests. So we see this is a very kind of positive and promising kind of result from this AI application. So another other kind of studies such as like the right figure, people also want to do the evaluation, compare the GPT model, those AI model with real patient, with real physicians. So this team come from Stanford. They have evaluate and published on Nature Medicine. They evaluate GPT model with a physician and GPT plus physician. So before I read this kind of paper, my first impression is okay, maybe the result should normally will be okay. AI may beat physician alone, but AI plus physician will be the best performance. But this result is a little bit surprising, and they find that the AI plus physician has slightly less performance than the AI themselves. Although it's not statistically significant, but the performance is slightly worse than the AI alone. So that means for some cases, the AI, the physician can make the prediction even worse. So, but all kind of studies, we can see the very kind of positive kind of news that AI has very good performance on a lot of medical applications. But on the other hand, we also see some different kind of stories. So this one is published on New England Journal of AI, and they test GPT model, Gemini model, medical codes, just ICD coding, given this kind of EHR and do the ICD coding task. And their observation that those kind of AI is really, really weak. They cannot do those kind of tasks very well. So here's kind of coding, they just less than 20% of accuracy, this kind of exact accuracy. And so the performance is not like that kind of quality as we see before from other kind of study. Another study is also from German pediatrics. There are a group of physicians want to explore the GPT model and apply to the pediatric kind of case studies. They create 100 questions and using the GPT-4 to answer those kind of questions. Surprising that it finds around 83% of those kind of answers are incorrect by the AI. So its error is around 83%. So it's really kind of poor, low performance of this AI model. So we can see this kind of the result is quite inconsistent. Some studies showed okay, it's a very good performance on some application. Some studies say that's not good enough, even very bad. So those kind of inconsistent performance occur different kind of applications. But when people, such as when research or physician, when they want to pick some kind of AI or LLM to apply to their own applications, the common question come out is that okay, when and which kind of LLM perform the best on my specific applications, and how good, how bad those kind of performance is, and also they may also even trade, just make a decision by trading trade off different kind of settings. So do I have sufficient GPU? Do I have sufficient kind of money to use some kind of API of the GPT model, etc. So there are a lot of kind of considerations with when they choose different kind of LLMs in their own applications, and also. But the problem all is that LLM is evolve rapidly. They are almost every week, even every day, they have a new model coming out, having released out. So it is really important to want to benchmark this kind of advanced LLM in application in the medicine and healthcare, and also tracking this kind of new release model. When the new model release, we want to know okay how good all this kind of new the model have improved compared with the old versions. And so this is really necessary to show to benchmark the performance of and they do have a lot of evaluation and benchmarks. So just here, kind of, it's not a complete list, but just some typical kind of list. So med QA, people using USME, some medical exams. PubMed QA, they are using PubMed kind of abstract as input and have some questions answer. And also some other kind of medical exams. Health branches come from OpenAI. They have kind of curate specific kind of scenarios for answer. And some other kind of settings. Also has a kind of benchmark for biomedicine. It's also mostly based on the PubMed and some kind of additional data source. And another group of evaluations, they have another kind of isolated evaluation on specific clinical scenarios. As the example we have shown in the previous JAMA Pediatrics paper, they have create some specific scenarios in the clinical settings and ask to do those kind of tasks to evaluate on their specific scenarios. But the problem is that those kind of existing kind of medical exam, they are oversimplified, especially for medical exams kind of benchmark. They overly simplify the task. Such as those kind of medical exam, normally they have a situation, create kind of well-structured kind of situation and some 4 or 5 different kind of options, and you ask them to pick one, which will be the best option from those kind of candidates. It's not represent the real world kind of applications. It's oversimplified. The task is clean. The text is also very well organized. They also have some kind of option for you to choose. So it's oversimplified. Another series is that this kind of isolated clinical evaluation. They can evaluate on the real kind of cases, but the problem is that they are really hard to generalize. We don't know how they have some kind of conclusions or finding observations from their such as pediatric kind of settings. We don't know how good other kind of elderly patient application and also those kind of evaluations when they publish, they have a new model already come out. The model evaluations are already outdated. So we want to know what are the most advanced model, the performance on those kind of specific scenarios, but we don't know. It's really hard to identify kind of performance of those kind of state-of-art model performance. So there is a lack of dynamic benchmarking for on diverse to try diverse kind of real-world clinical tasks, and also the new model comes out, we want to capture this kind of new performance, the performance of new models. So those are basically just background. So there's a need for benchmark to evaluate the state of LLM, and specifically we have some additional kind of needs, such as we want to focus on the real world clinical text rather than those kind of medical exam. The real world text is quite different. Real world clinical text, especially the EHR in extra has record text, they are totally different from what we have seen from PubMed, those kind of medical exams. They are well grammatically correct, well organized, and well complete sentences. These kind of text, although they include a lot of clinical status, history, procedure, medications, kind of all the clinical most relevant kind of clinical information. Those are documented in the EHR system notes, and many clinical, most of the clinical decisions are based on those EHR data in the clinical practice. And so those are very, very important to use to understand the kind of type of text. And but the problem is that this kind of text is messy. When you really look at kind of formally all those EHR data, it's not well organized, a lot of abbreviation, even um, typos, and grammar is not correct, and a lot of kind of numbers mixed with text, those kind of things. So it's have a lot of kind of challenge when you use AI to understand this kind of text. So another kind of characteristic we want to have this kind of benchmark is that we want to include not only English, because it has already been explored by a large number of studies, but there are many more languages that has not been studied, especially for those kind of real world kind of text. So we hope to those kind of benchmark includes multiple language, and want to include those kind of experiment the settings will be large scale rather than only one single data set. The problem will maybe not be generalizable, and the task want to cover different type of tasks to make those kind of results or conclusion more consistent across different kind of tasks. And in terms of the kind of model side, probably we'll discuss the data, the benchmark the dataset side. For the model side, we also want to include not only those kind of GPT model, Gemini state or Gemini model, but also there are a lot of needs for open source models, especially in the healthcare settings. People may don't want to have the data released to those kind of commercial companies, although there are some kind of institutional agreement which can allow them to using this kind of model with HIPAA compliance environment, but they do have another kind of needs to for groups that want to use open source model to run this kind of local model with their own server, which may keep the data safe. And also have there are different trends of model. Some are general kind of domain model, some are fine-tuned model on specific medical tasks. So medical model versus general model, which model we should choose. And also for different kind of groups, they have they are not always have a large number of GPU, 100 GPUs. So we want to think to balance, okay, which kind of model or not, which size of the model we can choose based on the performance requirement we want. So we have a want to compare with different model, the model performance across different kind of size, and also have want to have the benchmark, this kind of leaderboard, which can dynamic people, any people who has their specific needs, such as I want to have a more have good performance on German, I want to have a good performance within 30 billions of model, small model, and etc. have their own kind of criteria, and they want to choose based on this kind of dynamic kind of settings. So we hope have this kind of readable. So for user, different kind of user can have choose their own kind of subset leaderboards. So now we go into our recent work with a kind of bridge. We benchmark the general model for unsetting real world clinical attacks. So our bridge dataset benchmark is the dataset itself has include 87 different kind of tasks. They are all from real world clinical attacks. Most of them are EHR texts, and importantly, some of them are from the real patient and physician online discussion. So there are still also the real interaction between patient and physicians. So that we regard them as the broad EHR data, and we evaluate 95 of them. In this our paper submit. Well, actually, we already evaluated more than 100 LLMs, including DeepSeek, GPT, and Gemini, Llama, and also the recent kind of Gamma 4, all those kind of things. So we have keep tracking those kind of new models to add them to those kind of evaluation model family. And all experiments were conducted on the HIPAA compliance. Although some they say that we are it's open access, but such as Mimic, but they are still required. You need to run with the HIPAA compliance. You cannot direct through them to ChatGPT, these kind of things. Otherwise, they are user agreement. So all experiment was conducted under HIPAA compliance environment settings. So the bridge it include 8 different type of tasks. In terms of NLP, national processing tasks, such as question answering, so in the right corner, down right corner, similarity, semantic similarity, inference, summarization, coding, that's be similar with RCD codes, and also NER, this information extraction, event extraction, also text classification for some diagnosis or treatments kind of recommendations, those kind of things. We have 8 different kind of NLP tasks. Because different tasks have a different evaluation metrics, so we just kind of custom them based on the NLP tasks, and they cover many different kind of clinical applications. So we run extensive kind of experiments, more than 24,000 of experiments with around 40 minutes of inference. Now it's definitely over the kind of 40 minutes of inference to have new much more models included. So these are the language you have. It covers 9 languages: English, Chinese, Spanish, Japanese, and the rest of kind of language. So we require each language will include at least 3 datasets to ensure relative robustness of the evaluation. And we have a leaderboard, and we can choose use those kind of leaderboard to test, choose based on your own kind of needs. So those are the very basic kind of overview what we have for those concepts. And now we go to the detail. How do we construct? What are those kind of results? We find interesting results. We compare different model and some interesting observations. We also go even further. Why was this kind of observation happens? So we can go first for how do we construct this kind of benchmark, so, step by step. So those are dates are the majority of data are sourced from one of our previous New England Journal of AI paper. So we do a very systematic literature review. That's before ChatGPT area. So we just do this manually. So we screening more than 3,000 kind of literature papers and identify those kind of real world clinical data sets. And in the end, we identify around 192 clinical data sets that are real world, that come from derived from real world clinical scenario and all text-based kind of data set. And then we send, and also all those kind of data sets in the paper, they claim that the external user can request their data through reasonable kind of usage. So we just do this kind of settings. So we send them one by one, send hundreds of emails to those kind of group. And if they not respond, we send another group email after 3 weeks, etc. Try to have, we have a strict kind of protocol for the content of those kind of authors. And in the end, we have get around 100 datasets. 91 have accessible, fully accessible, and 14 are regular accessible. We can still access this kind of datasets. 87 are inaccessible datasets. So in total, we have around 105 data that we can use to construct this kind of benchmark. And after that, we also have a search data from additional kind of sources such as Hugging Face, which is commonly used for model sharing and dataset sharing. So we also do additional kind of search from this kind of additional kind of database to get more kind of data. So in the end, we have aggregated more than 100 kind of dataset, and then we can do some kind of data filtering, such as we ensure each dataset will have at least 200 samples to ensure that the number we report on this dataset is robust rather than too random because of kind of limited kind of data sample. And also for each language, we have we only include a language that have over and equal 3 tasks, include over and 3 tasks. And those kind of data are must have to be clinical relevant, that come from real world clinical environments, not from medical exam, expert curated scenario, assumption scenario, synthetic data. They all need to become from real world data. And so in the end, we have include 87 tasks with covering 9 language. So for each tasks, we evaluate different kind of models. We have 3 different kind of inference strategies. One is the zero shot, the basic one. Just input those kind of settings, text and the instruction of the task, and ask LLM to do the task directly. And the fusion will just random pick 5 examples and in the prompt, and also ask them to do the task. And the COT is a chain of thought. We ask them to think before they do this kind of final task. So those different each kind of experiment will have 3 different kind of settings. So we have a custom diverse evaluation method and metrics for different NLP tasks, such as so for the NER memory recognition, kind of event this extraction set we use F1. For some classification, we use accuracy. For some kind of summarization, we use some birth scores, kind of things to evaluate different kind of tasks. And in terms of the model, and we have run the most advanced kind of model, the Gemini, DeepSeek, GPTs, and we did not include the isotropic cloud model because we cannot find a HIPAA compliant environment to run this. Because that'll be one limit, but the rest of kind of advanced model we can run. Then the OpenAI C0 series and Gemini series, we can run this kind of model. And also many advanced kind of open source model, we can run all of them in one local GPU. So we have in total we have 5 proprietary models, 17 medical specific models, and 17 reasoning models. But now we have actually we have much more reasoning model because we have included more recent kind of model. In total, we have 107 something like that, LLM models evaluate. And the model size is quite diverse, from 1 billion to 671 billion. That's DeepSeek R1. And for the proprietary model, we don't know the size, but we have different kind of proprietary model. So it's covered a lot of kind of LLMs. And so now let's go to the result we explore, we find based on this kind of large scale of evaluation. So here is a very brief kind of trend figure to visualize the performance of across all the tasks. So we average the scores of all the 87 tasks together and compare different size of models. So here you and also we can see the time trends. So for the red dots represent the proprietary model, and for the rest of dots are represent the open source model. So we can see that at the beginning is the beginning of 2024, January 2024, the ChatGPT actually has the proprietary model. The difference between proprietary model and the open source model is quite big. It's around 10% of kind of score, 10 score of 10, and with time goes, especially for the Llama 3 and Gamma 2, this kind of model release, the difference between open source model and proprietary model is quite close, become quite close. And that sometimes the early of 2025, when the DeepSeek R1 release, it's actually beats the rest of the open source model, commercial model from the open source model. And when the Gemini 2.5 release have go back to the program model go back to the first place, and they have a new model Gemini 3 is still on the investigation. And but we see the general trend that the difference between open source model and commercial models is becoming smaller and smaller with time goes. So at that time, the evaluation time, the Gemini 2.5 Flash achieved the best form model, and definitely we can have this Gemini 3, but it's much more expensive. We're still finding some way to run them on this kind of expensive model. And so let's go to the details of some typical model. Those are the most kind of top models. Although the last one, the medical is not top model, but that's with the very earlier kind of medical specific model. We have used them to compare with others. So here, for each model, they have 3 bars. And the first bar represents the zero shot, just ask them to the direct prediction. The second bar represents the COT child thoughts, ask them to do thinking first and then do the final task. And the third bar represents the few shot. We'll give them 5 examples. And we can see that the top 4 model is that in terms of on the zero shot settings, that's Gemini 2.5, DeepSeek R1, GPT-4, and Queen 3. Also the open source model. DeepSeek R1 and the Queen 3 are the open source model. The rest 2 are the proprietary model. And one in terms of those kind of few shot settings, the Gemini 1.5 Pro is gives you the best performance. It's 55.5. Score get the best performance. And but if we look at this kind of compared from zero shot and few shot, we see that all of them have a kind of a significant kind of improvement with this kind of 5 examples. And then we can think about, okay, for the small open source model, if the small open source model such as the Medgamma 27 billion, I'll be here. And if we add them, kind of give them five examples, the performance is 52, which is largely outperform these most advanced kind of proprietary model without examples. So that we can see that giving them a slight kind of example will be very cost-effective way to improve the model performance. But another interesting observation is that when we compare those zero shot with COT settings, ask them to do thinking first, and the majority of model have observed that the COT decreased the model. With those can ask them to do thinking first and then do the kind of task, the model will have a drop across most of the models. So that will be very interesting because when the COT was first proposed in many kind of general domains, especially for the medical for the math calculation, they do see another kind of improvement with COT. They think step by step and the performance better. But here we see quite consistent result that with the COT settings, the mode have decreased. We'll expose kind of COT fails in the following slides. So here we give a more fine-grained comparison with different kind of NLP tasks. We categorize them across different tasks and see the performance. So here each figure represents the specific NLP task, such as this NER, name recognition, recognize kind of terms from the text, text classification, NLI, event extraction, etc. And this is coding. So generally, those kind of when we look at this kind of number, the performance is not that ideal, just such as the NER, name recognition. In the medical domain, real medical, the best model is 49% of F1. But if we compare with the general domain, such as the classical general domain NER dataset is a Cornell 2003, and the performance is around 94 or 95% of F1. So this is really behind this general kind of settings. So we do not see this, those kind of on this real world text, they do not perform quite well compared with general domain. And if we compare different kind of categories, we can see that they may have a relatively good performance on the NLI, natural language inference, but this will be a relatively simple task with a binary classification. And they can have a reasonable performance on text classification, around 70% of accuracy. But for the NER, I would say it's much lower than the general domain. It's only just half of the performance compared with the general domain. And especially for this kind of coding, normalization and coding task, the performance is pretty poor, and it's just less than 10% of accuracy. But this observation is consistent with what we see from the beginning. They have an example that during a general AI paper, they also find that the LLM is really poor coder for the medical settings. So it's consistent with what they observed. And here we want to compare, because we're covering different kind of language, we want to compare the model performance across language. So here those are represent, each kind of direction represent in a specific language. So we can see that it's may not quite clear from the figure, but we based on numbers we calculate, we can see that Gemini 2.5 can be best in Chinese, Spanish, German. GPT-4 best in Norwegian, Japanese, DeepSeek best in the Russian and German. So different model have different kind of preference kind of language, and this figure, the left figure and the right figure, the difference is that the left figure represents the general domain LLMs. The right one that represents the medical specific LLM, and they are all in the same scale. So we can compare them left and right directly. So we can see the clear trend is that the general domain is normally will have better performance compared with the medical specific LLM. But this is a many kind of studies have already observed content. So the reason would be like those kind of all general domains that come from big companies have not updates very quickly. So a lot of kind of medical specific models such as MetaGamma and MiNAMA, they are trained only on Llama 2. When they're after the training, they have new model, Llama 3 has already come out. So it's a little bit kind of hard to compete with those kind of commercial companies to find those kind of medical specific LLM. So here we want to explore the scaling law, because with a very important kind of rule in the AI community, that's the general principle is that when you have a bigger model, you train on the sufficient kind of data, you will have a better performance. That's what's going on. So we also explore those kind of experiment laws still hold in the medical real world medical tasks. So we choose the four different kind of model families that have different kind of size of model. So we do see this trend is quite clear. Even under different kind of inference strategy, zero shot, COT, five shot, we do see that with different kind of when the model size increase, the performance actually is generally increased. It's also hold here. So those are the some kind of interesting observation we see from the large scale experiment. And But as I mentioned, that we do find some kind of interesting kind of topics based on the previous analysis, such as the first one is the why the COT. We will compare the zero shot and COT, why the COT fails in the real world medical data, but they do have improved or very good performance in the general, especially the mass calculation. And we'll try to do additional analysis on this kind of question. Another one topic is that because we already have all this kind of outputs with kind of if they have COT or the region text, they have this kind of analysis text. We want to identify the stigma language. That means the stigma means some language are offensive to patients, which is a kind of new topic. Is a popular topic that people are worried about in EHR notes, but also for LLM output text, it still includes kind of offensive language to patients. That may destroy the trust between patient and physician if we apply the LLM directly to the healthcare systems. So we also explore this kind of direction. So we have two additional analyses for this topic based on the experiment we already have. So here we go first for the COT fails. So if we look at all these kind of models and compare the zero shot and the COT settings, the majority of them must have the performance drop. So here, the red square represent the COT performance, the green represents zero shot dot. The majority of the performance, actually, we have a stick system, 87 or 86 or 83% of models have a performance drop with COT settings. They do have some kind of slight models here, gamma 3, I think, have slight improve. Maybe can't find them, but most of them have a model performance drops. But so we do a kind of lot of analysis based on this kind of questions. So the beginning, setting up the seminar just based on those kind of our experiment result. We'll do additional analysis, such as we'll compare the model, different model, the difference of the COT and the zero shots across the model performance, and also have a reason length. Some kind of COT have a name, different kind of names, maybe different names have a kind of correlation with the performance drop, and also have the additional kind of medical concept, such as we extract specific kind of concept from the written text. Maybe some concepts are more relevant to the performance drop, some concepts are more relevant to for the performance increase. And also the lexicon different analysis, just for some COT success cases and COT fail cases, we compare the lexicon. What are the text difference between these two patterns? And also have error analysis. Want to explore all those kind of COT failures. What are the main problem of those kind of errors? So we do have LLM judge and also have expert review. So we do not list all the results here due to the time limits, but this presents some kind of initial but interesting observation we have. So here is that we observe, or we just compare the model performance drop compared with the model performance. Such as here we have already explored 95 models. Based on their model performance, we group them into 5 different kind of categories based on performance. We just rank them first from top to down and pick the top 20 perform the model as group, and the 20 to 40 perform the group, and time goes on. So we can see, and then draw this kind of figure. The y-axis represents the performance drops. So we can see for the top performing model, although they all have performance drop, but the top performing model drop less compared with the bottom model. So we see this kind of clear kind of pattern that the COT course not dropping in the weak models, but this, although it still creates kind of drops on the strong model, but the drop percentage less compared with the weak model. Another observation is that we want to explore, because we are thinking about the COT reasonings, maybe different kind of reasoning lengths have some combination with the performance. So here we draw this kind of figure from, or pick 4 typical LLMs and compare their kind of performance drop with the reasoning lengths. So here we can see, so this one, the dash line represent the direct prediction, and this one represents the COT performance. So and the red one, red curve represent the difference between those two. So we can see almost across all 4 kind of models with the longest reasoning kind of length, the COT length, generate token length, the drop have a more drop compared with the length. We don't know the reason, but we see this kind of correlation. It's hard to explain, but we just observe this kind of interesting kind of trend. Maybe the longer kind of thinking lengths are related to the tasks are more it's harder, and on this kind of harder tasks they have a bad performance on the COT settings. We don't know, but this will be very interesting observation. And another one was mentioned that the next in comparison. So this figure represents we have a group the COT output in the two groups. One group is the COT success. That means the original zero shot has wrong prediction, but COT has the correct prediction. And another group is that COT fails. The original zero shot is correct, but COT are incorrect. And we group these two kind of groups, and we compare the COT text between these two groups. So each dot here, the x represents how frequent of this word in this kind of COT failed cases. And in the y-axis represent how frequent of those kind of words in those kind of COT success cases. So if you look at those kind of the upper right, upper left corner, those kind of words represent they are high frequent in the COT success cases, but have low frequent in COT fail cases. And similar to the right down right figure location, those kind of words are represent the COT have very high frequency in the fail cases, but have low frequency in the success cases. So we're using this kind of again distinguish the kind of the test distribution across two groups. So here I have also have analyzed automatic generated kind of top failure cases. We can see from the top success cases, it's hard to find some specific pattern, just the tabulate this kind of medication, etc., and just general kind of medical trends. But it's interesting to see the top failure cases. For there are not all kind of terms, especially numbers or units, are quite frequent in the fail cases, but have no frequent in the successful cases. So that'll be a very interesting observation. And then we do some kind of error analysis. We do have a human. We use an LLM chart here. We use the GPT-03, and but we before that we use human evaluation to ensure that the LLM judge is have the reasonable kind of judgment to judge this kind of errors. So here we categorize these errors in three groups, three different categories. One is hallucination. That means you generates some kind of facts that are not exist in the input or just fabricate those kind of facts. And omission, that means the input have some important clues in the input, but just ignores kind of important clues. Incompleteness means that when COT do those kind of predictions, they do not have a very complete kind of reasoning chain. Just skip a lot of steps and give the final steps, make the wrong prediction. So do those kind of error analysis. So here we can see from the GPT-4, its hallucination rate is higher than the rest of the omission companies. And Quinn and Llama, they are similar. The hallucination rate is the main problem of the errors. And omission and companies is less. But here for the Mi Llama is finding from the old version of Llama 2 and with mimic data and some additional data. And the housing rate is similar to Queen and Llama, but they do have a lot of kind of omission and complete prediction for this kind of model. So that'll be the analysis of this kind of why COT fail. We do not have very clear kind of answer for why, but we do find some kind of interesting clue that we can report. And we also have an ongoing project to moving deeper to see explore why it's kind of happen. How can we improve that? We may kind of for some kind of term, some kind of information, we may use some kind of external kind of information to help them to do to improve the COT reasoning kind of accuracy. So it's an ongoing project. So another kind of interesting topic we have explored based on the result we already have, large scale experiment we already have is the stigma language. That means it's defined by the NIDA. It's just another discrimination against the identical group of people or place. And there's some examples such as in many EHR texts, they have a document the patient was alcohol abuser, the patient is clean himself, dirty patient is dirty, etc. Those kind of terms and words, yeah, actually is they call stigma language. That not respect to the patient, and but that will reduce the willingness to seek the treatment and stereotype. and also have some other negative effects. So here is some example. It's not completely, and there's some examples such as the patient have a addictor, user, substance or abuser, or those kind of things, alcoholic, drunk. Let's say they have used some kind of general kind of term rather than do not have too much kind of discrimination to the patient. So this has been explored by many studies, but there are more studies to explore this kind of stigma language in EHR nodes, the physician written nodes or the nursing written nodes, and but schema identification in LM generated text, there are not too much exploration, especially in those kind of real world clinical data is understudied, and there's no systematic evaluation uh, to the best of our knowledge currently exists. But as we all know that LM tools, kind of AI tools, the generated AI tool has become increased integrated in EHS. So many systems, the text summarization has been generated, text are generated by LLM. So those kind of AI generated context already be integrated into the EHR nodes. So the text, many of the texts are already generated by the AI. So this is an urgent kind of patient safety issue to explore those kind of AI generated kind of nodes they do have a stigma language or not. So here we have another kind of experiment, but the beginning is the same. Here we are just noticing that we have 35 English data. We only pick the 35 English data sets rather than the 9 language we export from the original British benchmark, because the reason is that we only have the identification, stigma language identification tool that are only based on English. But we have an ongoing project to try to extend this kind of language, this kind of tool to capture more kind of language, stigma language from more language. But it's just future work. But here we just report the 35 English data we have, and on this kind of 95, actually it's 107 LMs, and to explore what happens, what are the stigma language rate distribution. Um, uh, and also compare that for some input, because they have EHR input, the schema language in input will result to higher rates of schema and language in output, LM output, just be a constructed correlation between each other. And so here is a very general figure to realize these 35 tasks versus 95 models. So the we can see the schema language kind of actually rate in if you look at all the pairs, then the highest kind of rate is 34%. It's a very high. It's from by M2, which is have a very non-reasoning context. And for some typical models, the GPT-4, they also have a rank from 0% to 12%. So some datasets, some tasks, the GPT-4 can generate 12%, or the 12% of the output will include those schema. So those are not negligible for the adaptation to EHR system. In average, they have for GPT-4, they have 2.3%. That means every 50 kind of maybe 40 generate kind of document, they'll have at least one document have the schema language. And we compare models, different type of models. So here is the left one represent the reasoning and non-reasoning. We can see that the reasoning model have higher rates, but it's not surprising because reasoning they generate much longer kind of reasoning text, and maybe have higher chance to include kind of human language. And for medical with general models, we can see this general model have normally have a higher sigma rate compared with the medical one. So one guess is that the medical model are trained a lot from the EHR data. Those EHR data similar rate normally will have a lower rate compared with the general text. They have a more kind of similar rate. So they have that's why you have the medical model have a slight lower similar rate. Also compared with the open source proprietary, so proprietary have a lower kind of similar rate compared with open source. So that may be because those kind of proprietary model have those big companies have their own kind of red team within their group before they release model, they have this kind of assessment to reduce this kind of discrimination text or during the output, and also to explore that different kind of those types. So some when those are means the input on those type. So when LM processing the discharge summary progress node, they have higher rate of generating the schema language. It's not surprising because they generate a lot of content, analyze a lot of context, But if you look at the input radiology report, are very specific on admission notes. The rates, the LM output rate is much lower compared with the rest of those types. And here I also want to explore, okay, some EHR, the inputs, they may include schema rate, schema language, and LLM can just enlarge this kind of rate when using LLM to automatically process this kind of text. So here we realize this kind of figure. So this one, X represent input schema rate, the Y represent LLM output schema rate. Each dot represent the pair of model and tasks. So if the dot under is 9, so that means the output schema rate will lower than the input schema rate. But if the over is 9, that represents the LM will enlarge this kind of schema rate. So we do see some actually it's not little. Some many model have or can enlarge the kind of schema rate if the input have this kind of schema language, but they have generate much more schema text with LM. And so thus be the we see that some model, some kind of on some task, they do have can enlarge kind of discriminative text when applied to the settings. So those are we for some kind. These are still ongoing project. We have a management drafting, and we also have the additional analysis ongoing. We just report is kind of some interesting result we have. So the brief summary of the talk is that we have built the largest and most comprehensive, to our knowledge, of benchmark. They are built entirely on the real working data. They are all from the generated from the real world interaction between physician and the patient, and all in the EHR systems. And it's cover multi-language, and it's transparent of all the detailed prompt data settings. They are all transparent. All the information since have been the appendix of the paper and have a regular evaluate. So we have a large number of experiments covering different kind of settings and scenarios, and we have a leaderboard. We can dynamic update this performance with the new model. So we also have some kind of findings and the further explorations. So the open model have increased comparative, and some different kind of model tasks have a relatively good performance on some type of tasks, but struggling on some other tasks, especially the coding task. So also do some kind of additional kind of further analysis why the COT fails in the when we deal with the real world text, and also we may be the first analyzing the schema language in the real reasoning on large scale. So our hope is that we want to have this kind of benchmark to serve as the assertive foundation for the evaluation of LM, and also definitely include the new release model. So this is a joint team from another many institutions from Harvard, Stanford, MIT, Mayo Clinic, and the UIUC. And if we have data you want to contribute or more you want to evaluate, we are happy to talk. And that's all my talk. I'm happy to take any questions. Thank you.
Thank you, Ji. This is really informative. And you definitely have done a lot of work in terms of LLM evaluation and then examining the different success modes, failure modes. So I'm going to start fielding questions from the chat. First one, it seems like prompt engineering is still and perhaps always will be a very important factor in using any LLM. And can you comment on what you think about the importance of prompt quality, prompt engineering?
Yes, definitely. So this is also one common question we see, such as when we analyze the COT settings. Some reviewer will criticize, okay, you are using, so some tasks you need to customize your own COT text. You will have your own kind of prompt, right? So just you want the prediction, you want to have some kind of background information of the disease. You need to think based on these 5 steps, standard steps. So prompt themselves definitely be very, very important in another kind of setting. But here, what we did, we just using a very unified prompt. So we compare them in the fail settings. But if you apply to your own kind of scenario, definitely the prompt settings is still very important. But what we see from our experiment, we have some internal experiments on our MGB kind of EHR data. We see at the early stage, this kind of old models is they are very sensitive to prompts. You have a different setting prompt, the prompt actually will vary a lot. But with this new models, the Gamma 4, the difference, they still have difference, but the difference is not that big compared with the old model. But they do have a still have an important kind of thing. We normally have insert some kind of background information, such as for a specific task, you are following some kind of protocol, some kind of you need to think from this angle or another angle, some kind of modifying grant, and you want to guide them to think those kind of steps. Yeah.
Great, that's cool. And then question on your bridge benchmarks.
Mhm.
So bridge moves from exam style benchmarks towards real-world EHR-derived clinical text. And in your view, what failure modes become visible only when we evaluate LLMs on the real clinical documentation rather than medical board style questions?
Sorry, can you repeat the question?
Yeah, so the question is in your view, what failure modes become visible only when we evaluate LLMs on real clinical documentation
Mhm.
rather than medical board style questions?
Yeah, that's a very interesting question. So we did not compare those kind of failure cases directly from the medical exams, but what we see many papers that such as when you apply this kind of medical exam have different options A, B, C, D settings, right? The answer actually they are sensitive with the order of this kind of options, such as you put those kind of the optimal option in the A or B, those kind of things. They may prefer to answer A, something like that. So that'll be the kind of stability of the those kind of medical exams. But here we didn't direct compare with them, but what do we see? At least the CUT fails is what we observed from this kind of real world kind of benchmark. And I did not know if this kind of observation still holds in the medical exam. But we see some kind of specific pattern in our kind of benchmark. We do not explicitly compare with fail case with medical exams.
I see. So you think that the different modes of the COT failures has been exposed with the help of the real-world clinical documentation.
Yeah. Yes.
That's interesting. And then the next question is a little bit philosophical. So how do you benchmark the benchmarks? Uh,
Okay.
if the benchmarks are novel, how can they be considered a gold standard? And if the benchmarks are not novel, is it possible that LLMs are trained on so much data that the benchmarks are included as part of their training data?
Yes. So maybe I do the second one. So second one is related to kind of data limitation, right? So a lot of kind of data have been released, the benchmark have released, and they may already include kind of things. We have a digital scenario or supplementary. We do some kind of digital analysis for data limitation because some data such as mimic, right? Even they are have restricted access, but the people can still access, and we don't know those kind of open, those kind of model includes kind of EHR nodes or not. So we do some contamination settings, and the majority of the tasks and the models is they do not have too much problems. So you look at this kind of figure, because most of those kind they are from EHR data, so they are not easy to download. Even for Mimi, you still need to do the CT training or this kind of settings. It's not kind. It's hard to be crawled automatically by the crawler from website. So it's a less uh, kind of that's an issue compared with kind of some medical exam. Medical exam is will be have a suffer more about this kind of things. Those kind of a lot of open source data and can just download easily. So here we such as here we have to those kind of we do find some models such as maybe I think this one they have a MedMe I think, yeah, it's a Minama 17 billion model. They have this kind of mimic N2C2 mimic dataset. So, but they do explicitly mention they are trained on mimic data. So we can identify this kind of contamination. That's not be a problem, but the majority of model we in our benchmark, they don't have too much risk on the contamination problem. But for the first question, how do we benchmark the benchmark? So here, what do we there are two levels. One level is that how do we get the reference standard of this kind of data set. So all the reference standard we have will come from the original data set. So that'll be one limitation. We do not re-annotate by ourselves with a team or clinician. That'll be too heavy. I don't know. I don't have spent sufficient money and the time to work on that direction. So we trust the original data source, but they do have some kind of recent news. They say that okay, some medical benchmark data they are fabricated, they are not real, right? But we do have some quality checks, so it should not be a big problem from our side. But another thing is that the benchmark themselves, right? they have a lot of impact factors, such as you have to define the prompt, how do you compare those kind of models, and some model have their specific kind of prompts. You need to optimize the prompt for the specific model. So it's really hard to build a kind of very kind of perfect kind of benchmark. But what we can do here is that how to use our benchmark is that, okay, if we have our own list, I can only support afford maybe less than 30 billion of model. So you can click our website, our leaderboard, choose maybe top 5 model under 30 billion size. And you can run this kind of 5 model on your own kind of data set and do the kind of evaluate comparison by yourself. But the way is that we can help you with pre-filtering the majority of the model. You don't need to run all the model less than 30 billions. But this can be a kind of very initial kind of filtering for you. You only pick the top end kind of model for you to choose. So yeah, that's the answer.
Yeah, thank you so much, Dr. Young, for a really tour de force. And I just want to applaud you and your team for doing such a comprehensive
Thank you.
amount of tests and number of models. I think you actually just answered the question that I was going to have in that, for the teams that aren't able to do such comprehensive evaluation of so many different models,
Yeah,
what kind of guidance? And sounds like using perhaps the leaderboard that you guys have already filtered and recommended is a
yeah.
good place to start. So thank you so much.
Thank you.
Thank you, Jie. So I think we have 1 minute, and then perhaps asking a question about the COT.
Mhm.
So you observed that COT actually weakens, is worse on the weaker models,
Yeah.
right? So I think this is important. And then do you think that the COT amplify model weakness by creating more opportunities for hallucination, or does it reveal weakness that were already there but less visible in zero-shot answers?
Yes, that's a very important kind of question. Yeah, they do. We do see a little bit similar here, right? If you look at the BNAMA model is compared with other models, we can regard the weak model, also it's medical specific model. So you can see they have a lot of kind of problems of omission and conversation. They have a relative close kind of percentage compared with the rest of them. Although the GPT-4 is much better, but for the Queen, the advanced model, it's have a close conversation, but they do have a lot of failures from the omission. They may ignore some important information from the input, and their reasoning, their kind of output, because those are kind of I don't know how it's not kind of just from my guess. They are those kind of old part of model. They don't have very good kind of reasoning text to train because they at that age they don't have too much kind of reasoning text to train them. So their reasoning, the path is not well kind of explicitly trained. So their reasoning may have another problem. Amid a lot of kind of information, the reasoning steps are not complete. They may have this kind of problem. But this will be very interesting kind of important direction we want to explore. And why is kind of weak model. Some model are even not the old model. They have some new model, but such a small model, they are, still have can have a larger drop. So we don't know, but we can definitely can explore in depth for the error patterns.
Yeah, absolutely. I think this is very interesting and important.
Yeah,
And so we are at the top of the hour, but I want to thank you again for a very informative talk on LLM capabilities on real-world clinical data. And this is really tour de force. Congratulations. And for
thank
the
you.
audience, I wanted to remind you that we will reconvene in a couple of weeks. So when our colleagues and friends from Emory is going to present to us. So stay tuned. Okay, thank you everyone. Hope you all have a good rest of the week. Take care.
Thank you,
Thank
Dr.
you.
Young. Thank
Thank
you,
you. Bye. Thank
everyone.
you, Dr. Noor. Thank you.